fine.
Awesome. Thanks, guys. Yeah, my name's Thomas. I'm a clinical therapist for a site group called BCS out of Novi. I started off as a CNA for a couple of years, and you guys have really hard jobs. Just any type of caregiving, and just I have a lot of empathy for you guys. It's not easy, especially if you're working with folks with dementia. It's just very, 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 very challenging. So a lot of empathy for you folks. Keep it kind of, it's more of a refresher, kind of discuss things. But if you have questions, please feel free to stop me or anything. I'm very passionate about dementia and stuff. So anything you guys have questions, please stop me. Today we keep it kind of chilled, so we'll just identify different types of behaviors, different approaches, and then different ideas on meds. I know it's not really the scopes, but just kind of discuss that a little bit, and then how it impacts you guys as well. So what are different types of behaviors associated with dementia? When you think of behavior with dementia, what comes to your guys' mind? Aggressive, yeah, good job.
Confusion.
Yep, confusion, yeah, good. Yeah, agitation, you guys said that. Restlessness, yelling all the time, taking their clothes off, hoarding, stealing, wandering without purpose, because that's what wandering is, without direction. Aggression towards staff, you guys, other residents, it's difficult. Hypersexuality, verbal abuse, physical abuse, just a lot. So these are all things, different types of behaviors. And then most people with dementia, most 30% approximately are non-compliant with medications because it's poison. So, and then difficulty sleep. So then as clinicians and as people we work with, we say, well, when is it a problem? Because we all have behaviors. Everything we do is a behavior. Well, when is it a problem? If it's impacting functioning. So if we think of dysfunction, if it's impacting my ability to function, if I'm not sleeping, if I'm wandering into traffic, it's impacting my ability to function. And it changes. But it's difficult because their world is different, every single one of them. Not one person has the same type of dementia, and we still don't know what causes it. Still don't know. And there's no medication for it. There's medications for different things, but there's really no medication for dementia. There's things that slow it down, but not really. So then we look at, all right, dysfunction, it's impacting my ability to function. It's hard, and then it's your world. You guys have the stability, you guys have the rocks, you see them more than their own families do. So by a lot. So then you look at, in their world, perception's reality. So my perception of the world is my reality. So how I view it is how I view it, and how everyone views it. But then how do you change somebody's perception? So how do you change somebody's political view? You can't. People have their perception. But if they think the sky is gray or purple or yellow or anything, it's their perception. There's nothing I could say to them as a therapist, doing this 20 years probably, nothing I can say to them to make them, oh yeah, the sky's blue. Perception versus reality. So that's kind of a whole thing we kind of talk about today. Yeah, and how it changes and functioning, how we function. And it's never a choice. Nobody chooses dementia. Aggression. So we look at the aggression, and we look at how verbal, and we're looking at other residents, all these different things, and that is a problem because you guys are trying your best to make sure they're safe and they're this, and I know you guys are doing a good job because it's a nice facility, and but it's hard work, and it's hard work, especially if there's all these different emotions going on, to try to be the rock. So then if if they have all these different dysfunctional things going on, their perception's distorted because they have dementia and they don't understand insight and judgment, there's a lot of push and pull going on. So then you look at the problems of it in the context, the big picture of it all is, how's it impacting them? How can we make it less crappy? How do we make it a little bit better? Because you guys are doing a great job. You're making sure they're fed, they have water. A lot of them won't even drink water. You guys didn't buy that one. So you guys are maintaining human lives because at the day, it's difficult, and it is very difficult. But you guys are doing good. So when we look at a behavior, we say, all right, what is the behavior? What's happening? Is there a specific time of the day? What's occurring when the behavior? Because 95% of behavior is environmental. I'm not saying it's your guys' fault, but others impact the way they feel. whether it's loud stimulation or anything, a trigger from the past that they don't know about it. And that's hard, you know, so then you have all these different things. So that's how, when you're looking at a behavior and assessing it, or just trying to do the best you can by putting out the fire you can, when you're looking at it as a whole. And that's you know, the context of it all. Where is it happening? Is there a specific time of the day? Is there specific triggers? Is it after this or after that? You know, when we look at behaviors to help, that's how we approach it. Are there pain? Pain's real. Pain is real, but pain's relative to the individual. You know, everyone says, "Oh, that person's super tough," or that's, you know, they feel pain, but pain's real because reality is perception. So if somebody thinks that they're in a lot of pain, then they're in a lot of pain because that's how they're perceiving it. When you look at the behaviors, if they're new or old, you guys know your patients well, residents are. Your residents well, so you guys know when something happens or someone's off or somebody changes, you guys report it, and because that's how we assess behaviors, because we're the same, we're working our shifts, but as you know, we're looking at them and looking at the residents, and dementia only gets worse. It's degenerative. So assessing them and meeting them where they're at this moment in time is, they might not be who they were a week ago, a month ago, 3 months ago, which they're not because it's degenerative. So when you guys are approaching the behaviors and you're looking at it from the whole, there's so many different variables, medical stuff like that. Thirst, hunger is a big group. You know, you might not think it, but I'm learning oriented. So are y'all. If you want to take a drink, take a drink. If I want a piece of this cookie, I'll eat it. My brain says I'm hungry, and then I do this. It's behavior. But if their brain's saying they're hungry, but there's a disconnect between my hand to say, feed Thomas, and where do those feelings go? They linger, and it creates different things. Now, it's not your job to figure out the root and to do this, but I tell my dad, I come from family mechanics. They look at cars, and, you know, the more tools we have in my dad's toolbox to fix these cars, the better that any job would be. So that is my analogy, is as clinicians, the more tools that we have to help make your job easier, and then that's awesome. If you guys have questions, please feel free to stop. So thirst, hunger, mobility, pain, typical, very, very typical. And then how we look at mood. So if you think, all right, so there's a statistic out, so 50% of dementia folks have depression. So when we say clinical depression, it usually lasts 14 days, usually 5 symptoms. And we're talking depression, where you can get bed depression. And so if you think about half your folks probably have clinical depression. So that's wild, because you're saying you have 20 some or 15 some. You'd say half, and it's depression, where it's impacting their functioning. Yeah, that changes the way we view the thing, because then it helps us approach things differently. Half of them are depressed. Half of them probably have anxiety. So depression is our ability to sometimes, most likely from something from the past. Hard time getting out of the past, it impacts the way we feel. Anxiety, future-oriented, things that we can't control, very future. So you have somebody with dementia that can't process much, distorted thinking, thinks the sky's gray, getting kind of pushed through depression, kind of in the past, my kids, this, and in the future, worry of the unknown, worry about this, it's push and pull, and every case is different, but we can generalize. So if we're looking at it from, kind of depressive anxiety, all these different things, behaviors come out that we talked about in the beginning, the agitation, aggression, being upset, wandering, trying to look for their family, because I'll tell you what, sometimes, I don't want the feeling of missing a kid for a second is scary to me. It happened to my kid at Kmart once for a hot second, and I felt sick. So if you have people living in that distress, thinking that their kid's missing, that's true. That's a true behavior, and each place is different. But when you look at all these different behaviors that impact their functioning, that's difficult. So 50% depression, 50% anxiety. And then, yeah, don't throw in some delusions and hallucinations in the mix. Do you guys know the difference between a delusion and hallucination? Hallucinations are visual or auditory, thinking things aren't there, but they're there. So bugs, is a common hallucination. People think of bugs, so they're actually seeing bugs. We know that they're not, but they're seeing bugs from almost. So that'd be a hallucination. Delusion would be, my dad's the president. So not so much visual, but more of a delusion of my dad's not the president. So those are the difference is between those two. So then if you have folks that have that, but 40% of dementia folks have some sort of delusion, hallucination, where they're not seeing something's there that's not there. And then there's nothing I can say to make them believe otherwise. And then you look at it and they're thinking that there's something that's not. So, and that is, psych, we work, we provide the meds as best as we can, we do that, but there's been a kind of big change, and we're seeing a lot more psychological stuff in homes, and things have changed, so either A, we're catching it more now, or B, that's just how things are. So we're seeing more psychosis, more delusions, more behaviors and stuff than we've ever been, just because there has been an increase, which is what makes it difficult for you guys to do your job, because then things are changing. Yeah. You guys have questions? Am I talking too fast? Cool. All right. So if we look at the delusions, hallucinations, those are a lot of those are controlled with meds, which is a different thing. But and we'll get to kind of some different approaches at the end of this. So if somebody bumps into me in the street because they don't like me, is that the same thing as somebody accidentally bumping into me?
No.
Thank you. Great answer. Thanks, guys. Yes, because intent matters. Thank you. You guys are all right. So if we know in our head that if somebody doesn't intentfully try to hurt me, then it was an accident. So if they're not trying to annoy us and they're not trying to do this because intent isn't there, you're right. And there is a difference, because if you have a resident and another resident with intent, there is a difference than reaction. That's good. That was very good, guys. They're here for a reason, and it's like I said, it's not a choice. But they're at the memory care, assisted living, nursing homes for a reason. And if we know that, and we look at it from like, all right, most people don't wake up and want to go to a nursing home. We can generalize and say that. And so if we know that they're forced to be somewhere they don't want to be, in an environment that they don't know, it's difficult. It's difficult because then how are they supposed to? They're living because you guys are feeding them. And that's incredible. So I have a lot of respect for you guys, because what you guys are doing is providing Maslow's hierarchy of needs: environment, food, water, basic needs for humans. You guys are giving to people that don't even know that they need to eat sometimes. So when you guys are doing that, that is preventing behaviors. The more that we can be preventative, be mindful of their needs, and anticipate their needs, the better things are. If I try to maintain to eat myself, instead of just starving myself for 2 days, there is a difference. So anytime we're preventative, it's always good. So as when you guys do your thing and helping out, and when you're anticipating needs, the more preventative we are, wearing a seatbelt, the better things can be, even increases the car accident. They're here for a reason. There was traditionally a medical model for nursing homes, but then we are seeing a lot more assisted livings and memory cares popping up, because it's starting to come. That's just kind of a thing. And that's just changing the whole approach. And so I get asked a lot, why don't we just give them a pill? And there isn't really a dementia pill. There are pills that kind of help slow the process, and there are pills that help with the process, sleepings, other things, but not necessarily a medication for dementia, which means if it's not a med for it, then it won't work. It might help, but just momentarily. Because you don't want to let them sleep too much, because then they're going to fall and break a hip. So it's finding that sweet spot. And same thing with mood stabilizers and antidepressants. There is no FDA approved. So when you look at like wandering and pacing, or just taking their clothes off, or stealing and hoarding, there's no pills for that. There's pills that maybe help band-aid it, there's no pills for that. So then we say, all right, then what do we do? the interventions we do. We gotta do something, because burnout's real, and it's hard, and taking care of people's hard. Being a caregiver is real, and they just released a bunch of studies, especially with COVID and everything. It's been very challenging on everybody's job, y'all's jobs, and it's a lot. So when you have that aspect, it is trying. And with everything changing, when we can apply interventions, and the more that the tools that we have in our toolbox, the better things can be. Like I said, 95% of behaviors-ish are triggered by environment. So if we know that 95% of any behavior that you guys have to deal with is triggered because someone else or something bothered them enough, water, food, someone else, something bothered them, and they reacted. So the better, and we can only have so much control. I know you guys only have so much control too. But the better and the more control that you guys have over the environment, stimulation, stuff like that, those are non-pharmatic, things. If you go into a place and it's super loud, even myself, it gets I have to take a step back. So then you have somebody with sensory issues. It's pretty hard. So environment triggers most behaviors. So if we know something's going on, you see everyone else all amped up, what's going on, and like that. So minimizing change. Redirection and reassurance. Telling someone it's going to be okay is nice to hear. As humans, we love validation. We love reassurance. It's nice to hear that. Redirection. Now, it's not always easy. It's not like this cookie cutter, like, well, do this with me, and it doesn't always work. But that's what it comes down to. Each patient's different, and they all have their own backstory. So redirection, reassurance. Hey, I'm missing my kid right now. I can't find my dog. Oh, I'm sorry. That's terrible. Let's go look for it. So that redirection of so you're validating the way they feel. Validation, saying, all right, well, I hear you. How can I reassure you? It doesn't always work, but it makes things less hard. You validate, reassure, and redirect. And it's not always, in every case it's different, but providing that stability, that empathy, that care for others. Oh, wonderful.
So, I'm just curious which is the better approach. I've seen different approaches to it. I usually try, if a resident is feeling like, let's say like you said, lost their dog. I'm usually like, okay, let's go look for it. But I've seen other people just no, you're okay, everything's fine, kind of just try to bring them back to reality. Is there a better approach to that? Or are they both okay approaches?
Well, it does depend on, depend on their cognitive functions, you're right. So I think when you're looking at more like the Alzheimer's late stages, if they're thinking their dog's at a facility, they're probably, and I know that's just an example, but then I don't know where they're at in their reality, but we all know there's no dogs most of the time there. So it's always better to meet the patient where they're at, always and forever. So if they're distressed and they're trying to look for it, by me saying that there's no dog, but they think the dog's there, and they're crying about it, or they think their kid's.
Yeah, that's usually what I try to do, but I've seen two different approaches to it.
It's difficult. It's difficult to say, but we always look at the path of least resistance, and I've actually had to say this, so I don't want to lie to my patient. So I agree with that. But then at the same time, it's risk versus benefits. And is it lying, or are you meeting them where they're at because you don't want to cause more harm? So if I can I don't want to cause more harm, I'm going to tell my kid things, whether think something, but there is a reality of it all. But if they don't have the cognitive capacity to understand the reality, I'm just wasting my own time. I'm just wasting my energy on something kind of put a circle to square. Oh, good question. Great question. Yeah. No, time orienting someone most of the time doesn't work. Now it's difficult because there are so many different stages of dementia, and it's just there is no cookie cutter answer, even though I wish there was. I'm very passionate about this stuff. And it's but yeah, time orienting, it's path of least resistance sometimes. Yeah. I mean, you're not enabling a behavior because they have to have intent, but, trying to hit me in the street would enable behavior. But if they don't even know that I'm there 5 minutes later, that's not enabling nothing. Good question, very good question. Controlling stimulation, which I know you guys only have so much control over that. difficult and sometimes too much space if you feel lost, and that's, you guys don't have control for that. Tipa Snow, I've never known her to say her name. She's awesome. She's really done a lot of progressive stuff on dementia cares. So she focuses a lot on enhancing communication. So she always had a thing, approach from the front, which makes sense. But sometimes I don't do it. I always try to, then if we already know that they got some sort of sensory thing going on, they can't hear me, they don't know who I am, and I say, hey, gotta get in the shower. Who am I? You know what I mean? So, and not every case, but approaching from the front, that matters. It really does. When you approach, most of them have loss of hearing. You can't assume that they know anything. They're visually impaired too, which most of them have some sort of. So they got kind of their vision and their hearing. They don't know me. Yeah, approach from the front. Telling them kind of step by step, and this is common sense stuff, but it's one of those things. So step by step. Well, I'm going to do this. Well, I'm going to do that, because you're telling them step by step. Because if they don't understand what you're really comprehending, you can kind of help navigate. Having patience, which I know you guys do. Giving them 5 seconds to respond is a big one that she talks about. So if you think about it, it's 5 seconds right there. And you guys have jobs where you guys have to hustle. I know it. I know you guys do. I see you guys hustling. So 5 seconds sometimes, but giving somebody 5 seconds sometimes, if it can prevent a behavior like the seatbelt, the more preventative we are, and breaking it down into small tasks. If I say, all right, Thomas, I'm going to do this, and this. I don't even remember the first name. So approaching from the front, small tasks. These are all different approaches on how to really cope with that. Wandering is a very interesting one because without purpose. So it's so if I know I'm going to go A to B, I'm going to go to the store, I'm going to go pick up my kid, I'm going to do this, something. I got to go to work. I'm A to B. I'm going to my. But wandering is without purpose. So it'd be like just when you guys just walking down the street, don't matter, you're just walking. So when people wander, sometimes they do that. Keeping their hands busy helps keep their brain busy sometimes. On that, some people do like molding or different activities. Keeping their hands busy. Folding clothes is a good preventative and a good trying to keep somebody's hand busy for wandering, stuff like that. But it's tough. It's tough because we remember that they just did it. They don't remember they just did it. So then if they're trying to do something over and over again, they're forgetting about it. There's that push and pull. So they don't remember that you just told them 10 minutes ago.
I had a lady like that. Like we had this basket with towels, and I would dump them, and she would fold them. But like when she gets through folding, I unfold them, put them back in there, and dump them again. She would just sit there and keep doing it.
That is
but
great.
It stopped her from like wandering in other people's rooms and stuff.
Absolutely, it keeps their hand. It's muscle memory, so it's tactile. So like if I'm doing this, not really thinking about it, you just do it. It's like eating sometimes. So you're right, good job, because that helps keep their hands busy, then their brain's not saying, well, I need to go walk without purpose.
Focus on that.
Yeah, good, yeah. And these are things that, as a team, but and that's preventative. You're keeping her busy so she don't walk into traffic or walk someone's room or nothing to happen, to anyone. You're right, good share, thank you for that. And the more preventative we are as clinicians, the better anything, and I know you guys already know this stuff. I'm very passionate about working with geriatrics. I know you guys are trying their best. Everyone's trying their best. But the more that the mindful when I go to the patient's room and I go meet with someone, checking myself to meet them, because if they're impacting the way I feel, I'm doing my job. So if I'm letting them impact the way I feel, that's on me. So because it gets frustrating. I'm not saying your job. I'm not saying about you, but just talking about myself. So it does help with approach and empathy. You guys are in your jobs for a reason. So and I have a lot of respect for what you guys do. So those are kind of the various techniques that we kind of talk about. Different modes. Everything's different. Medications don't always work, and everyone's just trying. So there are different. If you guys ever have questions or for any of your residents, I do work with you know, with your guys' residents. So if you have questions about different treatment stuff sometimes, please leave me a message or anything like that. Do you guys have any comments or anything, or?
No.
Yeah, yes?
This is kind of off topic, but
You know it.
I used to do an activity with the socks, like having them fold. I still have a bunch of socks if you want me to bring them out for you guys, you know.
Well, there's a bunch
Yeah,
of,
it might, yeah. I think
Because they're
that-
like socks that aren't any ones, so you don't have